So we're going to now go into Dr. Hardesty telling us about our final words of wisdom. The state of GYN cancer in Alaska, COVID clinical trials, and new directions. And I asked Dr. Hardesty to do this because she really is one of, if not the best doctor that I've ever met. And, you know, an incredible partner in the journey. I could not ask for anybody more intelligent, more dedicated, more hardworking, more committed, and more able to tell us what should be coming next as we move forward.
Well, thank you for that gracious introduction. And I'm definitely not as articulate a speaker as all of those that preceded me, but I will do my best. Let's see here. I think I'm sharing my screen and we'll do it like that. Okay. So the slides are basically to just keep me on track. There are not very many of them. And I think Dr. Hope gave me a little bit of an opportunity to sort of talk about, we started this talk off with a really eloquent review of all that Luke has taken everybody through in the last 10 years. And we're going to end with a sort of a quick little preview into what's been going on recently and what there may be to come. So you all know who I am. I really think that we're all pretty done with COVID. So rather than spend much time talking about it, because I'm not planning on doing that, I thought I would just share with you what I would describe as my favorite memes as they relate to COVID and gynecology, and maybe just talk about some ways in which COVID made things better. So that won't take long because there's not much to say about that. Sorry, I don't know if you can try to move the Zoom bar out of there. I certainly got a good laugh about the visit to the gynecologist in 2020. But as you all know, when COVID happened, we had to look at our practice specifically in Alaska and figure out how we were going to make sure that access to care wasn't interrupted for our patients. And so we very quickly moved into a telehealth handoff. One of us, I in particular, worked out of my quite cold at that time of year camper with a moose out of the window doing telehealth while the other person was in person. And somehow I got my hands on that. Funny. I hope none of you are offended by the butt in the computer screen meme, but I thought it was pretty funny. And we are very lucky in Alaska that we were never prevented from really caring for our patients. We had to modify how we were caring for our patients, but we were really lucky that the hospital recognized how important it was to allow us to continue to operate and take care of our patients. And I never had to not operate on somebody, and I never was not able to give somebody chemo. We simply had to rethink the way that we were doing that. We were able to really successfully move our entire minimally invasive platform to outpatient surgery, which was remarkable, and our patients adapted with ease and grace to that change. So that's a little cheerlead to how COVID impacted us and allowed us to keep caring for people. And then, of course, the invention of the Zoom meeting. That little slide there is a screenshot of a journal club. One of the limitations of practicing in geography like Alaska is, of course, Dr. Hope and I ask each other for our opinions all the time, but we're also removed from the general sort of hallway conversation about latest trials and sort of things before they get published and so on. And so Dr. Hope and I are very committed to trying to make sure that we raise the bar and keep the caliber of care that our patients are receiving as high as possible. And the way that we do that is by engaging with others. And one of the great things that came out of COVID was that a lot of things in going online sort of opened up that platform for a lot of other people. So one of the ways that happened was allowing things like a journal club at the University of Washington that alumni could participate in. And all of a sudden, I was a little closer to the day-to-day hallway conversation. So that's one good thing that came out of COVID. And who can't laugh at the speculum meme? I certainly can. And then, of course, the mask for me. So anyhow, the pros for this really, is on some weird level, although it kept us isolated, there are certain ways, especially in a state like Alaska, where it allowed us to be a little bit closer connected. And telehealth, there are things about it that are undesirable, mostly that I can't be there in person, and certainly couldn't do an exam or lay my hands on a patient, but it has really helped me stay connected with my patients that are off-site. I'm much more able to stay in touch with them when they're getting chemo at other facilities. It's much easier for me to stay in touch with what's happening with patients in other geographic areas, which, for Alaska is like half of our patients, because I can see them, I can talk to them. Thankfully, most places people do have access to Wi-Fi, and if not, at least we're calling them, but it's just become much more accepted, and a lot of the privacy barriers have been taken down. So I'm very grateful for that. And I feel like there's no way that is going back in that box. Somebody took the lid off and that exploded, and there's no way that the population at large is going to allow that to go away. And I'm very happy about that. And so that's all I'm saying about COVID. All right, let's see. So the next thing on my title is clinical trials. And so this slide is, again, just here to keep me on topic. So as far as clinical trials go, we are also very lucky in that we are in a pretty unique position. And by we, I mean me and Dr. Hope at Alaska Women's Cancer Care, to partner with the Providence Cancer Center, who works tirelessly, whatever that word is, you guys know what I'm trying to say, to help us, have trials available. It's incredibly labor intensive to open these trials. And I'm very thankful to all of our patients who agree to participate in clinical trials. I know that it's more pokes and prods and x-rays and visits, and it's definitely a clunkier way of getting treatment, but the information that you contribute to sort of the general knowledge pool about how best to care for cancer patients is invaluable. It's super challenging for patients with our geography to travel for trials. Most trials require multiple visits. You basically have to camp here and to participate in a trial or elsewhere. And just camping elsewhere is just really not feasible for a large number of our patients. And so I'm very thankful to have the Providence Cancer Center research infrastructure that allows us to open trials and to make friends in industry that bring us trials. So, the NRG is the National Research Group. That's not what it stands for. I don't remember what it stands for, but it's the nationwide, trial group, specifically the gynecologic branch of it. And that is where trials are thought through and written up and go all the hoops are gone through to make them what actually go live for patients. And it takes a million people to do that, and millions of dollars. And so I'm very glad that we have that here available for our patients. Somebody asked in one of the sessions earlier, how do you get on trials? Know that, first of all, if you're getting care here in Alaska, we basically review all of our patients who are in need of a treatment change or new treatment every week at our meeting with the research staff on board. And so they right away are going to recognize if anybody would qualify for any of the trials that we have open, which I'm going to go over quickly. And so there's that. But we're not perfect. We can't always be thinking about everybody's situation with the same level of detail that the people in the situation can. So don't be afraid to go on www.clinicaltrials.gov, type in your disease, click, and see if there's anything on there that you wonder if you're eligible for, or that's in geography where maybe your sister happens to live across the street from a cancer center, and it would be easy for you to go down there and be on a trial. So, we are more than happy to facilitate that in any way possible. So I'm going to go through so trial lingo also, just so that was another question, just in terms of phase of trial. Phase 1 trial is a kind of trial where they're trying to decide whether or not something is is safe to give. Basically, is it too toxic, or can we actually give it to people, and how much of it should we be giving? Phase 2 is basically just trying that thing in a group of patients, expecting it to work, but not comparing it to anything. And phase 3 is more sort of the big, what's called a randomized clinical trial, where, it's compared to the standard of care to see which is better, in case you're wondering. So I'm going to click out of this for a second and just go to the trials that we have open. I'm going to skip over that one. We've had a couple of cervix cancer trials open for a while. These, thankfully, that cervix cancer is becoming less and less, so they take a while to enroll to. This is an upfront treatment trial for cervix that we've had a little bit of difficulty with because of some radiation stuff, so I'm not really going to talk about that. We have 2 trials open for patients that have undergone surgery and have either intermediate or high risk disease for recurrence, looking at whether or not the addition of chemotherapy to the radiation they would normally be recommended to get is helpful. Those trials, we've enrolled to a couple patients on each, and they're close to close. So we should hopefully be able to start seeing the results of those trials soon. So those trials have been open for a while. We have a lot of new stuff coming in the space of uterus and ovary cancer. This is the trial that we've had the most success enrolling in. It is a new trial looking at the role of adding immune therapy to sort of standard treatment for recurrent or advanced uterus cancer. So we're pretty excited about this particular trial. This is going to give us a lot of really good information. It's enrolling really quick. It has only been open for a short period of time. And to comparison, the cervix cancer trials have been open since I started working here. This is my 9th year here. And so this trial hopefully will probably be full by the end of the year, and we can start trying to figure out whether or not that's the right thing to do. There is a more nuanced, slightly harder to enroll to trial that's kind of what we call a basket trial, which is looking at recurrent uterus cancer that has certain specific test results on tumor testing and looking at different things for different groups of people. And we certainly are looking for people that meet these different requirements. Group C, which is absent from here because that's the one that was basically open to anybody, filled up in like 20 seconds. So unselected. So the rest of these are just going to take longer to find patients that meet these particular criteria. But ultimately, the goal here is really to get to personalized medicine. And I do think that we are, for the first time in my career, truly getting to personalized medicine. We've been talking about personalized medicine for a very long time, and I thought it was sort of not really something that we were actually seeing in practice. But to be honest with you, I really feel like, especially in the last couple of years, that really isn't true. We really are specifically able to target things going on with people's cancer. And then this is another uterus trial we have open for advanced uterus cancer. So and all 3 of these trials are just hot off the press, brand new, opened within the last 6 months. So congratulations to the research team for all the work that they put in, because as I mentioned earlier, it's incredibly difficult to open these trials, and research is not sexy from a nursing standpoint. It's hard to keep good people in these positions because most nurses like to be really hands-on with patients, and there's not as much of that. It's a lot more regulation and clicking, boxes and entering data and dotting I's and crossing T's, and it's just really not the fun every day. And so they've overcome a lot of barriers to make these trials available. But this is looking at a kind of hormone combination that's a hormone therapy plus something that's been used in breast cancer. So these are patients that have recurrent uterus cancer that we're taking an approach trying to more specifically target the hormone receptors on the uterus cancer. So we have lots of stuff looking at new things in uterus cancer. This is an older trial that's been open for a while. It's been closed for a while. I'm going to skip it. We are also in the line of things hopefully to be opening the next 6 months or so, looking at a trial for uterus cancer. That's a certain kind of uterus cancer. It's called papillary serous cancer, and that's kind of uterus cancer. It's a little bit more like ovary cancer. And this category of drugs that you see there with the word WEE1 is a category that's shown a lot of promise in uterus cancer, in ovary cancer, and also in this particular kind of uterus cancer. So we are hoping to be able to have that open, running, and accruing nicely is this trial. This is a trial. So now we're switching to ovary. Ovary cancer is once, the main drugs that we have aren't working so well. One where the side effects of treatment, unfortunately, are really strong, and we don't see as much benefit as we want to. So there's a lot of room for improvement. This is a new agent that we're looking at. And again, this is really personalized medicine because only about 40% of women who have ovary cancer have the quote satellite dish for this new drug, which is called mirtuximab, and it's targeting a specific receptor that about a little less than half of women have. So rest assured, if you're getting care in our particular practice, we are always looking for people whose tumors have this, and we'll maybe talking to you about it. And this drug is probably going to get approved through the FDA before the end of this year, which is really exciting to have a new drug that has really good response rates. This trial is close to being open. This is an immune therapy trial for ovary cancer, looking at a variety of different combinations of immune therapy versus standard treatment. Again, this is for patients whose tumors aren't responding to platinum anymore. So that's the same as this top one. And this is a great one because it lets us look at these things for people that have had lots of other things, which often makes them not eligible for clinical trials. So that I think we're going to have no problem getting patients signed up for. We are also looking at remember I mentioned earlier that whole thing about WEE1. It's a really exciting category of medications. And this, we're going to have an ovary trial open for platinum-resistant cancer, specifically looking at its use with a PARP inhibitor, which many of you are familiar with because you're on or have been on. And this is an effort to overcome PARP resistance. I'm really excited about this trial. The last two are not quite open yet. Neither is this one. So Hardesty and this one and that one are ones that are all sort of on the they're all going through all the procedures required to open them, but Piccolo is the last one, and this is looking at mirtuximab, which is in the Mirasol trial that we talked about earlier, for a different group of patients, people with platinum sensitive cancer. So a little bit earlier in the course of treatment. And this is also really exciting for those patients that have that receptor. So that is what we have open right now. And I'm super lucky to be in a situation where we're being offered participation in these trials. I will play the Alaska card for every opportunity that it gives me. For whatever reason, I think that people feel fulfilled by bringing trials to Alaska, like they're doing community service, and we'll take it because we love having it. So I love having the opportunity to get my patients groundbreaking treatments. New directions, we just continue to try to raise the bar. I train at University of Washington. My most important, or never important is the wrong word, my most influential, that's a better word, mentor was Dr. Barbara Goff. And that was one of the hardest days of my life when I had to waltz in her office and tell her that I was not going to take the job that she offered me at the University of Washington, but I was going to Alaska. One of the things we've talked a lot today about work-life balance, and that was really a work-life balance decision for me, with my life, and it was 100% the right thing for me to do. And when I told her what I was doing, she basically looked at me and said, don't get complacent, don't go up there and just do what you've been doing. You've got to keep learning and improving on what you're doing and making sure that the women that you're caring for are getting the state of the art. And so I want you to know that, no, I can't say stronger how much I feel that is in fact the case. Dr. Hope and I, which I call the PBJs, the peanut butter and jelly, that's my own little personal kind of way of thinking about us. I tell patients sometimes we're very different, but we're incredibly similar, and we make a great sandwich. So you can figure out for yourself who's the peanut butter and who's the jelly. We have different personalities that complement each other well, and we keep each other headed in the right direction. And I think that the combination really offers great care for our patients. We will continue to try to raise the bar. We will continue to try to branch out in Alaska, telehealth, and who knows, maybe someday a physical presence elsewhere. And, we have a wonderful team between the doctors and all that Let Every Woman Know offers for our patients, and supportive care and palliative care in our office, and the nursing, and really just every single person. And the new direction is this meeting is going to be in person next year, because I'm making halibut ceviche, and I got a caribou this year. Hopefully I'm not grossing too many of you out. So my caribou chili this year will be made with my own caribou. And this is just basically the reason I came to Alaska, because work-life balance is really important. And this is my life balance. So these are my people. And that's it. That's all I have to say. I think I'm exactly supposed to be done talking.
Thank you, Melissa. And thank you, everybody.